Today we'll focus on the location of symptoms when it comes to orthopedic disorders. I'm not going to talk about signs or baselines, but symptoms. And symptoms, because they're what the patient experiences, are subjective. And so the only time I can really glean symptoms are in the specific verbal history, which is part one of my orthopedic evaluation. As I mentioned before, there are three main parts to my orthopedic exam. One, the specific verbal history, and I say specific because I want people to know that we're asking quite specific questions. There's very precise information that is important for me to get. So part one is that. Part two is taking the baselines. In orthopedics, that's primarily range of motion, strength, nerve extensibility, and something functional like when I walk or when I roll over in bed or when I tie my shoes. Something that produces the patient's concomitant symptoms with that activity or function. And then third is testing. And by and large, in orthopedics in the United States, the thrust of that testing is orthopedic special tests, OSTs, and or images, primarily x-rays or MRIs. And while I use those in very limited cases, I can obviously do orthopedic special tests myself, such as the empty can test or the McMurray test or the anterior drawer test. I can also ask patients to go get imaging. I cannot prescribe it much, but I can ask them to get it. Those are rare cases when I find those types of tests to be useful. The main test I use is repeated movement testing developed by Robin McKenzie. And unlike those, it's not a quick, pull the tibia on the femur and see what happens. It's an algorithm, and it's using the verbal history, it's using the baselines, and having learned repeated movement testing to know where to begin and know how to progress with or without change to moving in a specific direction. So location of symptoms we glean from the verbal history. And what I want to provide people with is this idea that we really need to clarify all symptoms, because patients are going to focus on the one that's disrupting their life. They're not going to necessarily remember another symptom from 4 months ago in a different spot. So it's my job to gather that information. So if someone comes in with left knee pain, I'm asking, how is the shin or calf, ankle or foot? How about the front or back of the thigh, the buttock, and the low back? And I'm asking, is there anything in the other knee or the other side? I'll also clarify if there's numbness and tingling as a symptom, because I don't want people to just give me the symptom of pain and exclude the tingling because it's not as relevant to their problem, because that tingling tells me something. Again, it might lend more idea to the fact that these symptoms are coming from the spine. So getting all symptoms is really, really important. I will belabor that point to make sure I know exactly where the symptoms are. I draw them on the human body diagram that I have on my evaluation form. Sometimes I'll flip that form around and say, did I get it right? Are these the symptoms that you have? And if it's just one, of course, that happens too. Patients come in with isolated knee pain, the pain is just in the knee. But I need to know where else there are symptoms, even in the recent past, or maybe more kind of profound symptoms in a distant past, because that informs what I'm thinking diagnostically for a patient. A patient who presents with simply left knee pain, say anterior knee pain, and the person who presents with left anterior knee pain and right buttock pain are different presentations to me. Also, if it's left anterior knee pain, that's different from someone who has left anterior knee pain and left posterior knee pain. Then I start to think it's not necessarily the tendon. So we want to clarify where in the joint or where in the extremity it is. And again, if there are other symptoms in the extremity on the same side or in the opposite side. And when it comes to the low back or the neck, I'm clarifying, is it left, center, or right, or across the neck? I want to know exactly where it is, because again, it really informs the diagnostic process. Coming out of my specific verbal history, I've been taught, and I agree with this paradigm, that you should have 1 or 2 diagnoses at the front of your mind, just from taking the specific verbal history. And that's going to tell you which baselines to take, although they're pretty standard. But we don't have time to do every single baseline for every single evaluation. So what I'm getting from the verbal history informs the baselines that I take and then informs the testing. So when it comes to repeated movement testing, for example, if I think there's a higher likelihood of an extremity symptom coming from the spine, I will likely start repeated movement testing at the spine. But if everything in the verbal history and the baseline taking is pointing to the extremity, I may start my repeated movement testing there. It's based on prevalence, it's based on experience. So get all the symptoms, understand their pain, discomfort, tightness, aching, numbness or tingling. Those things can matter in terms of diagnosis. So here are some examples recently. And it's hard for me to remember how I kind of approached these patient presentations years ago before I started learning Robin McKenzie's work, but I know I wasn't doing it as cogently as I do now. Now I have a really solid understanding of referred symptoms, and in particular, what spinal joints can present as, meaning what can a joint in the neck or mid-back or low back that's tweaked, how can it refer symptoms or create symptoms mechanically in other parts of the body. So here's an example. I had a gentleman recently, and I will present his case because this case is so fascinating at some point soon, just isolated shoulder pain. So shoulder pain on one side, he'd been to months of chiropractic care and was told he had a tendonitis, but there was no change, no improvement. And he'd also been told by an orthopedic MD that he had frozen shoulder. And so isolated shoulder pain alone, that fact alone could be either of those diagnoses. But when I asked him about other symptoms, so I clarified, anything in the arm, hand, numbness, tingling, anything in the neck, anything in the mid-back, he said no. But I asked him about the other shoulder. He said several months ago it started there and that went away and now it's just here. So if we take that piece of intel alone, it makes tendonitis less likely, and it probably makes frozen shoulder less likely. Now I'll go a step beyond, because this is not just location of symptoms, but knowing that frozen shoulder can present sometimes bilaterally, and knowing that tendinitises usually get better with several months of conservative care, my thought process was to ask him, did you lose motion when that other shoulder hurt? And he said no. So that kind of rules out the bilateral frozen shoulder theory. Not entirely. These are just individual pieces of the puzzle. One piece of intel is usually not diagnostic in and of itself. But to me, if someone has profound shoulder pain on one side, it just gets better on its own. And now it's presenting on this side, and I will add he had major loss of motion in this shoulder. I'm starting to think spine rises to the top of my diagnostic list, my differential diagnosis, because the spine can refer to both sides, the spine can create signs in the shoulder, and a frozen shoulder that's on both sides, again, typically or would not present with no loss of range of motion. One of the hallmarks of frozen shoulder, of course, is losing significant range of motion in the shoulder. So just from those one or two questions, I'm starting to understand this person's presentation as I go down through the rest of my questioning, and then obviously taking baselines and doing repeated movement testing. And spoiler alert, so much of his shoulder pain, which was severely impacting function like sleep and range of motion, was improved by moving the spine, the neck in a very specific direction or two. So another example, a young woman presents, her symptom location alone: lower abdomen, pelvic floor, right groin, right inner thigh, right lateral thigh, and low back pain. So if we take those locations alone, we can ask ourselves, what could this be? To me, the only thing this makes me think is spine. It's the only thing. If there were tissue lesions, right, torn tissue, or even something more vague like tight tissue or weak tissue, which I don't think are ever really root causes unless there's an obvious reason that those are the causes. If we think about tissue as a problem, A tissue is not going to refer to all those places. A local tissue lesion is going to create local symptoms. If you tear your muscle, it hurts where the muscle fibers have been torn. So this is, to me, screaming spine. And on the evaluation, we looked at the lumbar spine when I got to repeated movement testing, and we found no effect with lumbar spine. So I moved to the lower thoracic spine, and that's where we found significant relief for her functional baseline, which was a lot of pain in sitting. So that became the test retest. We moved the thoracic spine into extension, and then we retested the functional baseline of sitting among the other baselines. But the functional baseline of sitting was markedly improved. But again, going back to what the theme is for today, this location of symptoms has to make you think spine or non-musculoskeletal, because I can't think of a musculoskeletal problem other than referred symptoms from the spine that could create all of those disparate symptoms. So if the patient comes in and they're just telling you pelvic floor, because that's the most pressing issue, it's the one that's really disrupting the patient's life, then you might start to think tissue, because there can be pelvic floor issues with those muscles that are tissue in nature. But if the person has pelvic floor plus all this other stuff, then the tissue hypothesis is really low on that list of diagnoses that I'm contemplating coming out of the verbal history or coming out of this specific question. A third example, a patient presented with headache, neck pain, upper thoracic pain, chest pain, left armpit pain, and left upper extremity symptoms. And I know I may sound like a broken record, but that is screaming spine or non-musculoskeletal, because I cannot think of another type of lesion, another type of orthopedic disorder that would present with all of those symptoms. It could not be, a muscle tear. It could not be a labral tear. It couldn't be weakness or tightness. Again, things I don't really agree with. It couldn't be, a fracture. These disorders do not make sense. If you get the entire location of symptoms and you do a good job of getting that information from patients, the differential diagnosis should become very clear. Again, narrowing it down to one or two diagnoses, hopefully, from the verbal history. And I've had patients where I ask them, they have low back pain and knee pain. I'm also asking, do you have buttock pain? And they say no. And then they'll come back on the next visit and say, Laura, I forgot, I do have buttock pain. I just wasn't registering it. So I allow that obviously to happen. People are busy and they have other things going on, and they tend to focus on what's really disrupting their life. So we gotta, allow for the fact that people might come back and say, you know what, you asked me about my other knee, and now that I think about it, I talked to my spouse and, he was remembering that I was complaining about my other knee 6 months ago. That information is relevant. And the final thing I'll add is that many times, patients, going back to the example of knee pain, they will present with isolated left knee pain and their right hip will hurt. And even if they bring it up, they'll say, my right hip is hurting because I'm compensating. And while that could be true, for example, you put someone in a boot because they break their ankle, their other limb can start hurting from walking in a boot. And that's compensation might not be the perfect word, but you've altered the biomechanics of the lower body. So things can start to break down or hurt. Disorders can occur in other parts of the body. But I will note that the right hip is also a sign of symptoms. To me, it's a symptom of a larger root cause or a different root cause than the knee until proven otherwise. I allow that it may be compensation pain. As soon as we fix the root cause in the left knee, the patient returns to their normal style of walking, for example, and the right hip pain goes away. Or maybe there's a left knee problem that has now been so severe that they have created a right hip joint problem. We need to address them both. But that idea of compensation, I think patients, it's one of the reasons they will not report symptoms, because they just think it's compensatory and therefore not worth mentioning and not germane to my need to understand where the location of symptoms are in order to get a better diagnosis. So I hope this helps, but clinicians can obviously take this and run with it in terms of their lines of questioning. And patients, I need patients to start to think about all the different symptoms they have, because when you really tally them up, They can give you a very different diagnostic picture than just the one or two symptoms that are most bothersome.